All right, I'm going to go ahead and get started. I'm Andrew Krause. I'm a second-year emergency medicine resident at Henry Ford Hospital in Detroit. Today, I'm going to be talking about a research study we conducted in our emergency department, which was a non-inferior evaluation for sexually transmitted infections comparing vaginal swabs to endocervical swabs. I have no relevant disclosure for this presentation. A little bit of background about why we conducted this study. Sexually transmitted infections have traditionally been performed with a pelvic exam and an endocervical swab. There have been limited studies, but ones that have come out have shown that vaginal swabs have the same sensitivity and specificity to those collected by a clinician. So we hypothesized that the detection rates would be non-inferior by using a intravaginal swab compared to a traditional endocervical provider collected swab. The methods we used for this study was a new protocol that introduced vaginal swabs to test for chlamydia and gonorrhea rather than the traditional endocervical swabs. We assessed data 10 months before the implementation of the vaginal swabs and 10 months after. Our eligibility included any female that had received testing for STIs in the emergency department. And then our analysis looked at non-inferiority testing for proportion with a non-inferiority margin within 1 percentage point for the absolute detection rates of STI. For this study, we had 22,291 encounters across 9 different emergency departments within the Henry Ford Health System. We had 11,700 encounters in the pre-implementation phase and 10,500 in the post-implementation. As you can see on this table, our results for chlamydia showed that there was a 0.1 percentage point difference between our pre and post-implementation, and we used a 90% confidence interval for non-inferiority, which gave us a p-value of 0.009. And for gonorrhea, there was a 0.5 percentage point difference with a p-value of 0.011. So the use of vaginal swabs allows for patients to collect their own sample in the right patient population. Now, this has to be women that are just wanting to be screened for STIs. They can't have any reported pelvic pain, no pain during sex, no foul or unusual odor. All of these symptoms would require that a provider perform the exam using the traditional pelvic exam and now using our intravaginal swabs. So far, there's been limited studies about patient-administered vaginal swabs in the emergency room, but the studies that have come out have shown that there's a high sensitivity and specificity of self-administered swabs compared to the provider-collected swabs. Some benefits that we see in allowing to have patients perform their own vaginal swabs include that it limits demand on resources and personnel. When the female patient is able to collect their own swab, they don't have to be moved to a pelvic room, and it doesn't require a nurse or a tech to chaperone the exam. That leads to more time for the provider, one less room that needs to be cleaned, and less demand on other personnel. The other benefit of doing it is that subjectively, I've been told that patients seem to be more comfortable collecting their own intravaginal swabs when they're asymptomatic. We're estimating around 10% of our patients are meeting criteria to be able to collect their own swabs intravaginally compared to getting the traditional provider collected swabs. In the future, we hope to get more formal data on how patients are perceiving this, whether they feel they're getting a different quality of care or whether they are willing to actually rank that they preferred performing their own exams. So in conclusion, ED protocol using vaginal swabs for STI screening, I believe, is non-inferior to the use of endocervical swabs for STI detection rates in female patients based on the results from our study. Here's a copy of my references, and I look forward to answering any questions in the chat in the future. Thank you.